So this week at Research Conference, we're very fortunate to be joined by Hayden Bosworth, who is here talking about implementation science, bridging the gap from clinical and health services research to population health. And Dr. Zullig was unfortunately not able to be here today because of a conflict. So Hayden will be covering the entire topic. So just a brief overview. So Dr. Bosworth is a health services researcher and professor of population health sciences, medicine, psychiatry, and nursing at Duke, as well as the vice chair of education for the Department of Population Health Sciences. His research interests comprise three overarching areas of research. One, clinical research that provides knowledge for improving patients' treatment adherence and self-management in chronic care. Also, translation research to improve access to quality care, and then finally, eliminate healthcare disparities. His expertise is in developing and implementing scalable and sustainable interventions to improve health behaviors and reduce the burden of chronic disease. He focuses on various methods of engagement, including telehealth, and works through health systems. His work predominantly includes low-income, low literacy, and disenfranchised patient populations. And he's led over 30 trials and is participating in another 50 involving 20,000 individuals and resulting in over 300 peer-reviewed publications. He also teaches classes, so I was in his class for the master's program, and I've had the opportunity to work with him on some implementation programs, and he's very knowledgeable, and we're excited to have him today. Thanks for joining us.
Thanks for having me. You don't have to clap yet. Wait until the end to see how it goes. So thank you, though. Leah is a colleague of, and unfortunately, well, fortunately for her, she is going to have a baby soon. So she set the priorities and decided that this was not as important as having a baby. So that's why you're stuck with me. Okay, so I did not know what the audience was, and so we're going to kind of do a broad overview and then dive deeper into some specific aspects of implementation science. So we want to first talk about what it is, why is it needed, and then we'll talk about two case studies and walk through those. Feel free to interrupt and ask questions as we go. I'm also, lunch is supposed to be coming at some point, so I don't know what, but anyway. If you're hypoglycemic, don't pass that on me. Go eat if you need to. All right, so you can listen to the news every day and see something new that comes up. And fundamentally, what we're trying to do is understand what are the evidence base, and then thinking about what that evidence is and how do we then put that into the healthcare system. And we'll talk about why this is so important. But in reality, those of you that do cardiology. We can continue to develop new technologies and things, but if you really look at it from a lifestyle is 65% of the issues here. So in many ways, we have a lot of the knowledge of what we're supposed to be doing. We're just not putting that into the system, or we're not using that. That's where, is one example of where D&I, dissemination implementation, can be used and think about. So this is always just helpful to start from a fundamental basic understanding of what are we talking about. So when we're talking about implementation, it's understanding the actions which the idea, decision, rule, procedures, or practices are put into use. This seems pretty straightforward, but this is actually really hard. So many of us do the trials, and from my own perspective, after doing this for a number of years, I could do a trial, and I could publish that in a really good journal. But then what would happen afterwards? I got promoted, right? And then I'm done, right? Is that what our job is? No. But what do I do with that information? Is it my job to then think about how someone's going to use that? How they're going to put that into the healthcare system? Is it my job to help facilitate and put that into a package so somebody else can use it? Because I sure as hell don't think anybody can look at a 3,500-page JAMA article and say, I know exactly what they've done, I know what the secret sauce is, and now I can pick that paper up, and now I can put it into my own healthcare system. Does that ever happen? No. As an editor of a journal, we generally just put an overview, right? And even there, what are the results? The results are yes or no. Did it work? Did it meet my hypothesis? Okay? in all my trials, I have never hit all my hypotheses, both my primary and secondary, okay? If I got an improvement of systolic blood pressure of 4 points, but I proposed 5, that's not I haven't met the criteria, right? So the other part of what we're doing with implementation science is thinking it's not yes or no. The question is, who does it work for, when does it work for, and for who? Okay, so it's a different question. Okay, but the idea though is at the end of the day, we have an evidence base. We're not just simply creating stuff out of the de novo. We have something. We know that it should work. We're not sure how to get it into the system. That is what we're talking about here. So, so implementation, it's a science. So I want to emphasize, this is not just arbitrariness, just random stuff, just throwing stuff against the wall and seeing what sticks, okay? It really is a science. There's the strategies you're looking at. There's different ways of doing this. You're trying to get people to, or organizations to adopt, and you're thinking about how do you integrate these evidence-based into the healthcare system and to change practice patterns. Now, everything I'm going to talk about is with the assumption that we're trying to change. Okay? I do want to emphasize that there's a new area of focus on de-implementation. So we do a lot of dumb stuff that doesn't get pulled out of the healthcare system, right? I'm not talking about that, but that's part of the field that we'll talk, that dissemination and implementation. I don't have enough time to talk about that. But let's just assume what we're talking about is moving everything proactively into the system. How do we do that? So before I jump there, the other assumption that I'm going to make is that we already know that this is evidence-based. It's something worthwhile to do, okay? We can talk there's a whole focus on how to identify what is worthwhile doing, and there's issues regarding about trialability, observability, and all those things that could be important. But the assumption I'm going to take for the sake of today is that you have something, you know it works, but you're not, now your goal is how do I move this into the system, okay? So what is implementation? So these are just some things here to think about. So this is a pretty broad area, okay? It's broad in terms of who does it, what the training and expertise is, and what the methods are. So, you know, qualitative methodology is really important here, quantitative methodology, quasi-experimental designs, health economics policy. So it's really kind of a much broader area, and it takes much more of a team effort. And I think one thing to think about is, at a minimum, when you're talking about implementation science, is it's asking the right question and then figuring out what the right methods are. Whether we realize it or not, we find ourselves knowing a certain type of method, that's what we're familiar with, and then we kind of use that to solve all our problems, right? So can I use logistic regression or mixed models for everything? No, I can't. So what we're trying to do is achieve what is the question, what do I need to ask, and then think about what the methods are to answer that question. Sometimes we've done this, Leah and I have tag team when we actually go to University of Basel in Switzerland and teach this course. You know, what we've also learned over the time is that terminology varies by country. And as far as a field, this is not aspects of implementation science have always been around. The issue is that as far as a field, it's only something in the last 10 or 15 years. And in fact, the journal Implementation Science, which is one of the better journals for this field, is a recent journal. So this also reflects, I think, some of the changes that are happening in our healthcare system, that we simply are knowing that we have to do something different to improve the healthcare system. So key terms, evidence-based interventions, that these are interventions with proven efficacy and effectiveness. Now, the other important part to this is it may have proven efficacy in a certain community or healthcare system. It doesn't mean that it's across all. So this is also where dissemination and implementation can really come in. You may have evidence that it works in this community or healthcare system. It may work in Medicaid, but I haven't done it in Medicare, or I haven't done it in a fee-for-service. And so wanting to also understand how do you take something and then evaluate it in a different system as well. So where does D&I fit? So a lot of us have spent time doing more of the efficacy studies and now moving into effectiveness studies, but where I think implementation sciences is kind of where we're talking about observational studies, implementation gap, and then here. Now, implementation studies also could be interventions, okay? Now, the one thing about that, though, that makes it a little more challenging is we don't typically have an opportunity to always do a true randomization, okay? If this was my class, then I would turn it around and ask you, why is it that I can't do a true randomization, or why should I not? I'll give you the answer. Part of it is it's unethical, right? If I know I have evidence base that this works, why would I randomize? I'd have to think about that. Now, however, I could do step wedge, I could do all these cool new designs where I eventually could give somebody something, but I may do it either on the healthcare system level, and I may do other alternatives. But it's really, I can't truly randomize and say, okay, you get usual care and you get the intervention because we already know that this seems to be working, okay? Now that does also introduce another interesting thing where we're using perhaps quasi-experimental designs. We're using these kind of new adaptive designs that allow us to still get a sense of what the comparison is. We always want a comparison, okay? So that's also important. So in my mind, doing a typical RCT is challenging, okay? I think doing true dissemination and implementation science is even more challenging. So if you like a challenge, this is a good area to go into. Because once you've done an RCT, you're not necessarily redoing the same thing every time, but there's kind of a playbook that you can use. When you're doing dissemination and implementation, it may vary, and you may have to think about alternative methods and questions. Just to, again, put this in perspective, it's what's interesting is, does this work? We have more focus on pragmatic clinical trials. What we're talking more is on the interventions effectiveness, thinking about outside of the research environment, and in the last column there as well, looking at fidelity and other aspects. I'll get to that more specifically, but the other part to think about is that a lot of this work is not happening in the traditional sense where it's in a kind of a clinical environment, okay? So some of the dissemination and implementation work, we're doing stuff with, I was just talking with Sean about retail pharmacy, okay? So we don't necessarily think about the idea of going out to, let's say, CVS and saying, okay, we want to do a program on medication non-adherence. And then thinking about how I would do a program where it may be 20,000 people. That's kind of some of the stuff we're talking about. So the other part, which we'll talk briefly about, is that also when we're talking about dissemination and implementation, we're typically moving from what would be, in my world, an effectiveness trial would be something like 400 to 500 patients, to something where we may be doing something with 20 to 30,000 people, okay? And that takes also a very different thought process because a in-depth intervention, typical health services research that we would do, would be pretty time intensive. I can't necessarily scale that up and think about that for a larger project. So when we're talking about dissemination and implementation, we're often thinking about issues about sustainability and scalability. And so I'll talk more about those terms, but it's important for us to envision what those are so that, because the way I develop my programs may have to reflect that if I'm doing something about scalability, I cannot maybe do an intervention with a pharmacist doing a monthly call. Okay, we have a trial currently doing that. We have patients getting a pharmacist call for 3 years, every month. That's a great program for the 283 people in the intervention, but that's not a scalable program, right? So I may have the best results, and this was funded by NHLBI, don't tell them this, but I'm not in a position then to put that into and scale that up because nobody is going to pay for a pharmacist to follow 300 patients, okay? So that's also part of the disconnection between what we do in effectiveness and what may really happen in a dissemination and implementation world, okay? Now what I can do is maybe think about what are some of the content that was done that was useful and then maybe put that into that dissemination and implementation model. Maybe I also would do a different model where it's not a pharmacist. Maybe I'm using somebody else. Maybe the frequency is different. But at the end of the day, typically we do our efficacy. Does it work? Yes or no. Then we do our effectiveness. try to think about generalizability. And now what we're talking about is how do I take that and then move that into much bigger picture real world situation. Okay, so, but some of the challenges, as I already alluded to, so here clinical trials, our focus is on internal validity, the efficacy, there's randomization. I put here a little focus on implementation. I do want to point out that even in the efficacy and effectiveness trials that I'm seeing funded through NIH at the moment, they are now explicitly asking for some discussion or some thought process on dissemination and implementation. We're talking with Eric Velasquez and his colleagues about his large iTransform project. And one of the things that we're adding onto that, hopefully, is a component on dissemination and implementation, because it's not enough to say I'm going to get a nice publication and demonstrate that it works. Now, what do I do? How do I get that information out there? And so because of the times that we live in, everybody wants to see impact quicker and not just simply a publication. And so thinking about who's going to use that, what information, who are the stakeholders, and how to shorten that period of time from doing the trial to actually changing healthcare. So while I put that up as clinical trials, there's less of a thought of it, but you do want to think about it if you have that opportunity. I also would emphasize is that what you don't want to do is do your 5-year trial, find your results, and say, hey, do you want my results? It doesn't work that way. So what you really want to think about is who your stakeholders are and involve them from the very beginning so that at the time you're done, that they may be invested in what you have and feel that this is mine. I touched it, I felt it, and I understand that. So implementation research focuses more on external validity, effectiveness. There are oftentimes a variety of comparisons. It's not typically one, it may be 2 or 3. So it could be pre-post, it could be a comparison group, and we're often looking at multiple aspects there. One other key component I think that differentiates what we think about implementation research from typical effectiveness is that ideally we are not paying for that staff to do that program. Now that could be very unsettling to think about. You have a program and you know it's worked, but now you're going to hand it off to somebody else. You're not paying them. They have to think about how this fits into their clinical care, and they're going to need to do that. Now our tendency is to say, okay, I'm going to pay them because I want to ensure that they do that, right? But that is not close to sustainability, right? If I'm paying them to do the program, that's not likely to maintain that sustainability. So thinking about how do I get somebody to want to use this and continue to use that is important. So typically when we're doing D&I work, we are not paying the interventionists, whoever those may be, okay? So that also ends up with low level of control, okay? So how many of you like to have a sense of control? All right, who does not? Who likes chaos? Well, so this is, an opportunity. If you do like chaos, then definitely this is an area for you. However, there is a way to rein that chaos in, okay? I won't talk too much about it, but you think about fidelity. You think about what are the core components. You want to ensure that people are doing that core components, but giving them some flexibility also that there's other pieces so you can kind of allow that variation. And I will say that with implementation, some of that variation is good because you can then see, okay, maybe it works in these clinics and it doesn't work in those clinics. So again, the question is not yes or no does it work, it's where does it work and for whom and when does it work. Okay, just again, some of the tensions. Our research designs for more trials tend to be more rigorous evaluation. We're using randomization, and typically our focus may be more on the individual unit. With implementation, we tend to do more cluster randomization. We may be looking more at the healthcare system level, not necessarily at the patient level. I think it's also important to understand, too, when we do true D&I work, what our outcomes are. So we still will look at effectiveness outcomes, blood pressure, cholesterol, but those are typically not going to be our primary outcomes. Those may be our secondary. Our primary outcomes would be things along the lines of acceptability, adoption, appropriateness, cost, feasibility, fidelity. So these are things, sustainability. So different outcomes to think about. It makes it a little more challenging when we're powering and thinking about our studies that way, but that's generally what we're trying to do. Some of the outcomes we may look at are efficiency, safety, as you can see, and then eventually patient outcomes to whatever extent those may be, morbidity, mortality. This also raises an issue that we've struggled with a couple of our randomized clinical control trials, that when we don't have the opportunity to get the clinical outcomes directly from the patients from us measuring, right? So oftentimes we may need to use EHR data or other things. So in some of the situations we've had, blood pressure, just as an example, if we systematically evaluate that, that's very different than relying on what's available in the medical records, okay? And for those of you that are clinicians, you know that patients come in, you know, they may not have their blood pressure is measured. You may follow up with it again, but those values that you're getting from that in that context are pretty messy, right? So if we're doing a D&I project, sometimes that's the data we're using. So think about next time you go into a clinic and you're asked to give a blood pressure, how many of you are going to be asked to sit for 5 minutes, roll up your sleeve, sit there quietly, and get their blood pressure done in an accurate, correct way? It doesn't typically happen, but we're relying on what's available. That's just one example. All right, so why is D&I research needed? So hopefully I've explained to you and you all that it resonates for you what it is, but I think it's important to frame why is this needed. And why, related to this, why we've created a new department of population health science, which one of the three focus areas is implementation science. So broadly, why would Duke invest in a new department with a focus on implementation science? Is it because it's just a nice field, or is there perhaps a need for this? I hope that I can convince you I think there is a need for it. So we know that there's a lot of good evidence. We have Get With The Guidelines and other various things. But there's a big gap in some places with regards to what we know and what's happening. The other thing is, some of you probably have seen this many times, there's a significant time lag from the time of realizing something works and actually getting in there, with the assumption that even when it is something effective, not everything gets eventually implemented. So, and if you, the way to think about this too is that how many of you would decline an R01, those of you that do research and write a grant? So, and if you do an R01, I don't know, I'm not that good at it, but it takes me 2 years to write the grant and eventually get it funded, right? 5 years to carry out the grant. How many of you finished the grant in 5 years right on the nose or asked for a no-cost extension? And then you publish the paper right after, right? Eric's in the audience. He knows that there's one that we're still working on after 3 or 4 years, but we'll get to it. That's the longest. But generally, you can envision that it takes up to 10 years, right? And what trial is definitively answers all questions and puts something to rest? Not many. So just the fact of how we set it up. Now that probably is the right way to go, but once we have some evidence, it shouldn't take that long to do. But that's basically on average where we are at the moment. And if you think about it, another way to envision this is that, you know, typically we may do a design, we may do efficacy, effectiveness, small couple of clinics. We may think about sustainability. Rarely do we think about scale up and then thinking about the system sustainability. So many of us may just stop at the efficacy and effectiveness. I published my JAMA article. I hope someone's going to take it and run with it and do it and change it and put it in the healthcare. That doesn't typically happen. We usually have to help facilitate that. So anyway, just another way of conceptualizing why I think it takes this long on average. So what's the problem? So we have an access issue, quality issue, and cost issue. These are just components for us to think about. This is Dan Berwick's model here, and I think it's also not just simply getting the evidence in there, but there's the issue of cost, access, and quality we have to think about. This slide probably should not be surprising to anybody, but even, what was it, just recently I saw a lot of discussion on how much we're spending on healthcare. So we're about 18% of our GDP, okay? And financially, what that means is that for certain manufacturers, like car manufacturers, there's about $1,000 cost on each car as a result of the healthcare costs that's going on. So to be competing in the job markets, we need to think a little bit about how we do care better and improve the quality. There is lunch out there, so those who are hypoglycemic, feel free to go out there. I believe they will stay out there, but do not hesitate if you want to go out and get lunch. So anyway, okay. So, but that's not all. So when we look at things, how is the U.S. doing in heart attacks? We've invested the most in research, okay? But if you look at it in terms of summary measures, we rank 17th. Now, part of what was recently, I was just reading today, was we may have more innovations, and we're funding a lot of that with regards to technology. And in some ways, you would wonder, is it fair that we're spending all this money and everyone else is reaping that? But nevertheless, we are definitely spending a lot and not necessarily getting the value that we would hope to perceive on that. This is just, again, another overall ranking where we are. People may be familiar. There's been actually a lot of recent articles on this that where the biggest issue with regards to the cost is, does anybody want to know what's driving that? Why? So in general, the U.S. quality measures aren't that different from a lot of the other Western countries, but the biggest issue is the overhead costs is driving a lot of that. So anyway, we're spending a lot of money wasted because of poor implementation. There's this Lancet article suggested about 20% of healthcare in the U.S. is wasted care. So there's a lot of opportunities for us. And one could wonder, do we need to continue to think about inventing new things, or are we in a position where we may have a good sense of what's working, but we're just, again, not getting that and using that appropriately? So not only, I want to also emphasize the other part is this is where dissemination comes in. So patients aren't receiving all the recommended care. So an opportunity for us to think about how we can use D&I to help improve outcomes. The IOM on quality found that there were serious and widespread quality problems. So one of the other things I didn't go into is D&I would also, we look at variability. So understanding why there are variations in quality is important for us to think about. There's been actually another article that was looking at racial differences recently and finding that certain groups definitely, no surprise, we've known this for a long, long time, continue to not do as well as others. And so thinking about how we can better identify, Karen Joint had an editorial on how we can improve quality and address disparities and thinking about that. And she was talking about alternative payment models. So, where D&I also is at the crossroads is where policy is, and thinking about different ways that we can transition from fee-for-service to other models to think about. Some of the challenges, thinking about recruitment, identifying interventions, integrating into existing clinic workflow. This is really important. We can create the best widget, but if it's not something that's used or found to be perceived as beneficial, it won't work. As we think about D&I, thinking about site champions, one thing we've learned from our own experiences is that as an outside entity, we can do a lot, but when there's internal entities advocating for something, that can be even more powerful. So thinking about who those site champions are. I have that working with IRBs. That's less of an issue now. There's more of an understanding of quality improvement, D&I, and true trials. But it's still something that we sometimes on multi-site trials, we still have discussions with the IRB on what truly is, what quantifies as necessary for what could be construed as waiver of consent versus actually getting written consent. And then thinking about how do we evaluate the intervention impact. So that also is important for us because when you talk with industry, they talk about the ROI, return on investment of a 3-to-1 ratio. And that's what they focus on. But the reality is, for a lot of what we do, we're never going to see a 3-to-1 ROI. And so is that the right model that we should be looking at versus thinking about alternative models of what is important? And in fact, colleagues of ours up in Harvard demonstrated that, yes, we could reduce, for example, heart failure readmission rates, but subsequently what happens? Oops, we increase mortality. So, with everything we do, there's unintended consequences. And so at a minimum, no matter what we're doing, we need to have the right environment to evaluate what we're doing, to see what happens. Because this in some ways is whack-a-mole, that sometimes we hit something here and something pops out over there. And if we're not watching carefully and evaluating appropriately, what seems to be a real advantage here may be a downside there. And we also may need to think about alternative measures of ROI that don't necessarily pertain exactly to cost, because we know from a quality improvement perspective, it's really hard to assess good quality, right? Just because you can get the data from an EHR doesn't mean it's the right thing to do. So ensuring that it's appropriate takes more time to do good evaluation. So in terms of some of the challenges, again, complexity of problems, we can't always control everything. We need to think about multiple methods. Oftentimes we're relying on weak data that's available. We are doing better at creating those sandboxes. But with, for example, some of the work we do with adherence, we get really good claims data, or we can get really good pharmacy data, but they don't always overlap with one another. And then if we think about adherence, a lot of the patient-reported outcomes that we know drive adherence are in neither one of those databases. So it's not surprising that when we try to find out who's adherent and what are the factors, relying on secondary databases is only going to give us so much. We have to think of all ways of collecting other sources of data. And then the challenges, I think, which are exciting, is truly developing experimental designs that can fit into these situations that allow us to get a better understanding of what's working and what's not. So let me just walk through 2 case studies that just kind of help us frame some of these real-life issues regarding dissemination and implementation. So this was a trial we did a while ago. It's called Take Control of Your Blood Pressure, TCYB. And this was a 5-year RCT, so traditional stuff that we would typically think of an effectiveness trial. So this was funded through NIH and some foundations. And it was a 5-year RCT using patient self-management and incorporating home blood pressure monitoring. And we did this in the local healthcare systems here. This isn't necessarily earth-shattering, but what we found was, before I show you what it is, the other thing is just to also envision what the theoretical framework is. So I just wanted to point this out briefly, but we have our chronic care model just to identify where we're going to focus our intervention. We have our health decision model, which helps us identify what the factors are that are of importance. And then we may think about our trans-theoretical model to help us think about how we change behavior. Okay? So I do want to point out, the point of this is that when we are doing D&I research, this is not atheoretical. There is a theory involved. Okay? And we need to think about that, partly because if we don't have a theory, what happens when we get results? How do we explain them? How do we justify what we're looking at and what we conceptualize in our model, the factors that we're looking at? So if I think about the context of adherence, I know from our own work that there's over 100 factors that are related to non-adherence. I'm doing an intervention. I'm not going to do an intervention with all 100 factors. I have to justify what am I focusing on. So anyway, I just want to put this plug in that theories are important and helps us, but we also know that you can go the other extreme, where in D&I work now, we have probably over 70 different theories. That's crazy. There's no need for that. Anyway, I think there's a happy medium there. In terms of just the trial, this is just basically, we identified about 7,500 individuals. We got enrollment of 50% and a retention rate. Now, see, this is where the D&I becomes important. 2 parts. One is engaging stakeholders. So while this is a 5-year trial, one of the things that we did do was engage Medicaid. So Medicaid currently is using parts of these programs that I'll talk about here. the other part is envisioning what the participation rate and retention rate is. So in terms of the class I teach, we oftentimes, we're worried about the recruitment because that's what NIH or whoever the funder is, they want to make sure that we're meeting our funding, our recruitment rates. I think one of the other important things that we forget about is the retention rate, right? So I would rather have a lower enrollment rate, but a higher retention rate. That tells me that there's a higher level of feasibility, and it may be that I have to envision who the right people are to get these into the program. So the other point too is that what we're trying to envision is one intervention is not going to solve it for everybody. We're trying to figure out who these interventions are relevant for, and that's where predictive analytics comes into play. And the last point too is as far as when we move into effectiveness and then into D&I, we try to limit who's excluded. We try to take everybody possible. I just put this up there. This is just kind of the monthly interventions. This was nurse-based. In the interest of time, I'm just going to move a little bit. I think that this helps with the external validity, understand who we're looking at. Just to point out inadequate income. These are here from the Duke Primary Care Clinics. 20% are functionally illiterate. In our own data for other studies, we find actually higher levels. So as we think about the programs and those lovely things that we get from EPIC, those handouts, to envision that we have a high proportion of individuals that probably do not understand and can use that material. Okay. So anyway, so here is the effects of the intervention. And this was basically home BP versus the nurse call. And one of the things that I think is interesting is that the home blood pressure monitor by itself over 24 months was basically explained about half or about almost 4-point changes in systolic blood pressure. So giving somebody a self-monitoring blood pressure, teaching them how to use it by itself could give you a pretty sizable improvement in outcomes. So if we now put this back into the kind of the D&I model, one of the things we want to think about here is another model, is the re-aim. So we want to think about the reach, the degree which the population is impacted. So look at the proportion of eligible patients who may be willing or able to participate. We look at the effectiveness. So basically we know that there was a 6-point change in systolic blood pressure, understanding that what the outcome is. Now the other important part too is that in secondary data analysis, we know that actually low-income individuals did much better in the outcomes. So the interesting thing is, so as a trial, we simply fit our regression line through it, hope that we get a significant outcome. We've demonstrated a 6-point change in systolic blood pressure as an aggregate. But in subgroup analyses, there were actually individuals or groups that did even better, and actually higher income individuals did nothing. They stayed flat. So what that also tells me is that there may be some indication that trying to find a better next version to think about who would be more likely to benefit from it. Because it's telephonic, what we realized was obviously it's access to care. So trying to find those people that have limited access to think about how this may fit and help them. Now on the other side of it is, this is great. But who's going to pay for it? In a fee-for-service model, if I'm doing this telephonic intervention, I have to think about what that business model is. So is it possible that there are, that it could be for bundle payments? That if there's that model set in place where you get a certain amount of money, that would perhaps incentivize you to do some type of telephonic calls. If it means that I am doing this call and you're not seeing the patient and can't get reimbursed for that, this intervention is no longer sustainable in this system, right? So we have to really think about that and think about what information do we need to capture to help facilitate that, because this was a nice paper, it got published, but if I don't think about those things, nobody's ever going to use it again. And then also understanding outcomes and factors impacting implementation. So one of the things that we did also was go back and do summative evaluations. So this is where qualitative research comes in. Not only did we understand who did it work for, but then we went back to the healthcare systems and said, okay, how did this fit in? What was the use of this? How can we ensure the long-term sustainability of this? What were some of the barriers? What are some of the facilitators? and really trying to understand some of those components. Again, it doesn't just stop with the trial. That's the part that also regards to adoption and thinking about the evaluation of it. And then I won't go too much, but the cost of the implementation strategy. So understanding how much time does it take for somebody to do the program, capturing that data, so that I can then scope out what the FTE is for how many people or what one nurse could follow if this was a nurse. So having that piece of information was actually for us, for Medicaid, was the most crucial part. So yes, they understood it worked. That wasn't what they were concerned about. What they wanted to know was how many people could this program follow so that if we were to hire, say, 3 nurses, what that type of program would be and how many people could it be followed. So this is kind of along the lines of what I've already discussed. The other part is thinking a little bit about, I mentioned the word sustainability, but also maintenance. So there's 2 parts of it. The sustainability is the elongation of the program. Maintenance is the idea of can I ensure some outcome or continue that outcome. So I can't do programs perpetually. So this is 2 years. That's a long time. So thinking about, do we have to do the same thing for everybody at every month, or can we start thinking about how we could possibly adapt it based upon needs? So one neat thing about with this type of trial is we have home blood pressure, right? Why can't I change the intensity of the intervention based upon those values? If somebody is doing well, I don't want to waste my resources. Okay? But if we take a typical trial, how would you all feel about some people getting a high intensity every month and then some only getting once every 6 months, but it's only based upon how well they're doing? So that is kind of a different way of conceptualizing it. It's not to say it's a free-for-all. You could scope it out so that you say, okay, every 3 months I check to see how the patient's doing, and if they're doing well, then they go on this level. If they're not doing well, we increase the dosage. So again, thinking about the maintenance of the effect as well as the sustainability. The sustainability increases because now I'm using less resources and I can increase and follow up more people. These are just some of the strategies that we could think about for pre-implementation. I highlighted some of them. What we did was, for us to do this, we actually developed implementation teams. This is lean management, PDSA cycles. So those of you who may do quality improvement, there is a nice link with D&I and quality improvement. So some of the techniques that are done and used in quality improvement can be used in this model. And in some ways, the idea of doing the cyclical PDSA where you're improving and trying to reduce the time and the cycle, envisioning how we could do that with trials. So how can we do these so that we can reevaluate and improve things and change them as we move forward? So that was a pre-implementation in terms of the implementation. These are just some things that we put in there. So we want to make sure that these are just some examples that one can use. I won't go into too much detail here, but there's the pre-implementation, there's the implementation, and then thinking about maintenance. And I just want to also reemphasize, with the issue with regards to maintenance is, in many ways our goal is to fund something and then keep that going, right? We can't typically get grants that are more than 5 years. And if we're in these communities, particularly if they're in disenfranchised communities, it's very unsettling to say, okay, my intervention and my funding is for this period of time. Thanks for participating, but my funding is gone, and I wish you good luck. So for us, I think our roles as researchers are that we have to think about how we sustain these programs and do that in the very beginning and not wait towards the end. So anyway, just something to think about. This one I'll just quickly go through. This is an example of where we don't have a lot of control. This was funded through Robert Wood Johnson. This again was a randomized clinical control trial, all African Americans with type 2 diabetes. Because of funding mechanisms, funding was limited. We could not do standardized blood pressure evaluation. This goes back to what I was referring to. We relied on values coming from the medical record. So the overall intervention, there's disease management, the intervention is telephone-based. and their psychosocial aspects, and then tailored. The more important part was the overall intervention was a failure. It didn't work, okay? And typically when we think of a trial and say, okay, we didn't meet the outcomes, we're done, right? Well, a couple things happened. One is, again, we engaged the stakeholder, which happened to be Medicaid, and they were involved with the program. And while our systolic, A1C, and LDL did not improve, those were relying on what was available in the medical records. And there was a lot of missing data, a lot of differential in terms of how many measures, the length of time of measurement, but we were relying on what was available. Now, we could have typically stopped here, but we didn't. And that, again, was because we had Medicaid and stakeholders involved. Now, we did find improvements in adherence, which gave us some hope that there was something working here. But what ended up happening was the randomized clinical control trial that we would typically do didn't work. But then we moved to Change 2, which was actually Medicaid, and then SETI was a Medicare project. So we went, here, let me show you here. So the differences that happened, so here was, if you look at Change, we had our nurses doing it in a structured, standardized way. We limited to only those that were diagnosed with diabetes. These were in 2 primary care clinics. Then we went to Change 2, which was Medicaid. They were involved. They actually adapted the intervention. The case managers used it, and they expanded it beyond just diabetes. And they went ahead and did the program. Now, the results would be that they actually improved A1C by 1%. Which is a clinically meaningful difference. And then SETI, which was 4 counties, they used the program as well. They also adapted it to their needs. So in all of those 3 examples, same fundamental component, but the difference was in the Change 2 and SETI was the ability to adapt it to the local community and using this as a tool. And so the nice, I think, story for us is that sometimes engaging those that are doing the real care may have better input than what we would typically do in a randomized clinical control trial. In both those examples, we got clinically meaningful differences. Now, that didn't result in a big publication. We just published this. This was in Translational Behavioral Medicine, okay? And nobody's probably ever heard of it. But nevertheless, the point is that it got published because what the story was, how can you adapt a program to meet the local community so that you can do something worthwhile and not necessarily stop with a null trial at the Change level there. So for us, the key components here were that there was the stakeholders were important. There's a balance between the fidelity and fit, so that if I don't take into account what the community needs, I can end up with something that's really cool, but may have no long-term sustainability. And thinking about how we adapt it is really important. So it's not the adaptation occurred, so for example, one group I remember early on said this is too high literacy level. We need to change the content and reflect what's local in our community, which is very unsettling as a researcher to say, wait a second, I'm going to let you adapt something. So making sure the key components are there, but making sure it also fits. That's where the balance between fidelity and adaptation comes in. So some of the take-home messages, understanding what the common factors are. Some of them are going to be simple, some are complex. Understanding what is the importance and what aspects of change are thinking about. Most change requires facilitation, so thinking about who those local champions are, what the training is. There will always be barriers, so understanding what those are, and those are going to vary based upon sites. And then also thinking about what the leadership, resources, IT, and inertia. I didn't talk too much about IT, but this is really a big issue when we're doing a lot of our programs, that the IT can be a big challenge to do something. And what I mean by that is, like, think about those of you who've done work within our local EPIC, right? How many can you literally take a program and put it into the medical records here? It's not an easy process, as you know, you've got to get into the queue. There's a lot of things you have to do before you can do that. So let me stop there and answer questions. This is kind of a overall view on dissemination and implementation. There's some handouts. There's a seminar, Summer Institute, that we will be offering through the department that if you're interested, feel free to sign up for. Just as a plug, we will, looks like we will probably be well on our way to having a master's and a PhD program in population health science. So for those of you that are interested, feel free to reconnect with us for a master's program next year. I'm Hayden. Leah, as I said, is not available, but would definitely be here to answer questions. So, Doc.
I'll wait for the mic.
Thank you.
It seems like this would be the D&I would work well with community-based participatory research, because that's the way you get a place where I've seen people get champions in the past.
Yeah.
It's slow as molasses. I mean, you talk about a 5-year cycle. It's more 10.
Yeah. So I think there's a question. It's more. That was a comment, but there's also probably an answer and a question. I would agree that there's some overlap. I think that how we define community could be within a healthcare system. It could be on a provider level. It is sometimes for this type of work, it is not for the faint of heart. That typically what we find is we create the infrastructure and then we're off to the races, and you can build on other projects out of that. This also is, if you take away your academics hat and you think about the real world setting and you work with industry, they're like, their model is they're gone in 6 months, and if you any longer than that, you already have 2 other project managers and somebody else is there. However, they don't think they have the content, they don't have the methodology or the science, and so thinking about perhaps maybe that's an opportunity where the traditional community engagement that you're referring to, I think, is terrific, but I also think this is where we have to think about how we can partner with our industry friends and add our methodology, our content, and build on their infrastructure where they may have access to 20,000 pharmacies as an example. So completely agree with you. But I think alternative models may also help move that molasses around a little faster.
As you think about how you approach a situation where you want to do a research-based implementation project, and so you want to provide some support to the organizations that are participating in the research component, but you also want to have something that's scalable and sustainable in the long run where you won't have resources. How do you sort of think about that up front, and what tools do you use to gauge how much support is appropriate for these implementation projects?
Yeah, it's a great question, Sean. So I think it's important to envision this question from the beginning, because again, if you think about it at the back end, then it's not going to necessarily, and that's why I use that example of the change, because even though it was a null trial, we would have been dead in the water and not gone further. I think there are a couple things lessons that could be done. So beyond identifying the stakeholders, starting early, also understanding what are the key data that they need, what are the milestones that they're looking for, what type of information in terms of the evaluation do you need to think about. The simpler, the better. Understanding how much FTE, the amount of time, effort that's required. This is where I think mobile health can be really lovely, because you can do this in a much higher level of scalability, but mobile health, it's a touch. There's only so much you can do. So, but I think it's telling that story and collecting the right information to be able to convey that, and then I think cost is really important as well. So, it's not to say that everything, and the other thing too is knowing when to cut bait. Sometimes certain things just need to be cut off, and then there's also sometimes you're just successful and it doesn't need to be continued anymore. So knowing when that's also, and I think that's sometimes our challenge is knowing that this just, no matter how many times I redo this, it's just not working, and I can repackage it, I can get funding for it, but it's just something that needs to be done differently, may just need to be passed. So I don't have a good answer, but I think there's a toolbox that one needs to think about. But the fact of just asking that question, I think, is a different discussion that needs to happen, is just to think about what happens afterwards.
Thanks so much. I really appreciated your comment about the intervention sites not being paid, so you're really studying what's happening in a natural setting. The challenge we've had there is that you still have to collect data. And so that nurse that is collecting blood pressures and saying how many people enrolled in the project and program, what are some strategies you've developed for having that person still report back those important data elements back to you when you're not paying them?
Yeah.
Are there ways around that?
Well, I think the most important thing is making sure this aligns with what they're trying to work on. So when we typically do some of the stuff on the VA side, for example, we may say there's a 2-to-1 ratio. For every one site that we get, we actually have to allow two, may have to reach out to 2, and have set criteria before they will be able to participate. And some of that may be putting up that they have adequate resources to support this. This is something that aligns. Now, sometimes we game the system a little bit too, and we'll say, okay, wait a second, here, we're going to pick the bottom 25% sites that are doing really bad. On the other hand, sometimes they're doing so bad that you just don't even want to bother with that. But this is the ongoing challenge, right? And so sometimes you have to differentiate between what the intervention of the program is and what the evaluation is. And this is where we've gotten burned a couple times, is relying on the medical records for those values. Now, one thing we haven't always done is gone in and said, okay, we can't pay for the labs, we can't pay for the full blood pressure assessment. However, on the other hand, we can do a better job of training those people in the system so that they're collecting that data in a more efficient and effective way. The other is thinking about other process measures that may be beyond the clinical variables. So back to that model, the slide I had on adoption and feasibility, and thinking about those types of process measures, knowing how many people get into the program, how many people finish the program. Those are some other pieces of data that may be of interest as well, that may be just readily available. It does take a little bit of creativity sometimes to get that type of data, though.
Great. Well, I'd like to thank Dr. Bosworth for joining us today. I think that was a really interesting and important discussion, and I think opens up a lot of opportunities for future research. And I'll apologize to everybody. The food got here late, and so it's sitting outside, and so there should be lunches for everybody to grab on the way out. Thanks.